All right. I think we have a good list that has streamed in. Good morning, everyone. My name is Andrea Morrison. I'm here today as a moderator for Oral Abstracts 2. This session is going to go from 11:30 a.m. to 1 p.m. Eastern Time. We have 5 great abstracts lined up for you, and everyone is excited to share their work with you. And we're really excited to hear from all of you as well. Um, for each individual presentation, it will be 10 minutes in length, and then we'll have 5 minutes of questions afterwards. If the attendees would please use the question and answer chat, the question and answer rather than the chat, that would be very helpful for us so we can have a great discussion and have the attendees prepared to answer questions for you. If there's time allowed at the end, we can allow for additional questions at the end. So if you're listening in and you have a question we didn't have time for, please just write it down, wait till the end, and we'll have some time to discuss it. So to start off, I'm very excited to introduce the first abstract, the impact of teach-back training for providers.
Good morning. My name is Misty Pascal, and I work for the University of Arkansas for Medical Sciences in the Center for Health Literacy. And today I'm going to be presenting on the impact of teach-back training for healthcare providers. To start off with, I want to acknowledge that our work was supported through grants from the Office of Minority Health of the Department of Health and Human Services. I'd also like to acknowledge my 2 colleagues who worked on this project with me, Anita Bakur, who is our bilingual program manager, and Jacob Cooper, who is our plain language writer. Today, I want to talk about the role teach-back plays in addressing low health literacy skills with patients. I also wanted to tell you a little bit about a project we directed where we assess the use of oral communication skills, including teach-back in healthcare settings. And finally, I want to share our initial evaluation findings from a series of workplace trainings on teach-back for healthcare providers. Of course, we have to start this with a little bit of information about health literacy and clear oral communication. I'm sure most of you have seen this slide before or this information before. Healthy People 2030 defines personal health literacy as how well a person can find, understand, and use health information and services to make informed decisions or take actions for themselves or others in their family. Low personal health literacy can make those tasks difficult for those individuals. The National Assessment of Adult Literacy tells us that only about 12 out of 100 adults have proficient health literacy, and approximately 35 out of 100 American adults have either basic or below basic health literacy skills. And these are the skills that individuals need to manage their health and prevent future disease. Up to 80% of what patients hear during office visits is often forgotten right away, and nearly half of what they do remember is incorrect. When you couple this with low health literacy, this can be associated with lower use of preventive care, higher number of ER visits, and higher number of hospitalization, admissions, and readmission rates. This makes oral communication between providers and patients even more important, and findings suggest that those communications should include a way to check for patient understanding. This is where the teach-back method comes in. The teach-back method is a communication technique that promotes understanding between provider and patient by having the provider explain something and then ask the patient to repeat in their own words what they learned, what they need to know, or what they're going to need to do. It's a cyclical process where the provider explains, then they invite in their own words, asking the patient to participate, and then they listen. And that listening opportunity gives them the time they need to see if the patient has the correct information and understood or remembered everything. This process is done in a non-shaming way. It's not a test of the client. It's actually a way for the provider to evaluate themselves and how well they explain something. It also gives them the opportunity to engage in additional communication if needed with the patient. The correct and consistent use of teachback can create opportunities to improve health. Teachback moves communication from passive to active, and passive communication, which includes reading, hearing, and seeing individuals recall very little information, at best about 50%. Teachback promotes active communication by asking individuals to talk while they teach back that information. This can also include asking them to simulate something they've learned. These activities increase recall up to 90%. The teachback method is highly supported. It's endorsed as a national standard of care by the American Academy of Family Physicians, the American Hospital Association, the Joint Commission, and similar groups. Results from HCAP surveys show that the use of teachback actually improved patient satisfaction with medicine education, discharge details, and health management information. We've also seen studies that show that teachback improves patient recall and understanding of discharge information in emergency departments, and even 30 to 60 seconds of explaining and implementing teachback improve patients' understanding and confidence. I want to talk just a little bit about the project that we worked on, and we'll start with talking about the assessing the use of teachback. As I mentioned earlier, we worked with organizations who received grants from Office of Minority Health for projects to advance organizational health literacy. Each of the projects and partnerships looked different, but I'm only going to discuss the projects today that included either assessment of teachback or training in teachback. In the assessment of the use of teachback, we performed on-site observations. We worked with 6 clinics that were identified as free or low-cost clinics, and they included family care, family health care, behavioral health, and there were also specialty area clinics such as maternal health and pediatrics. We had trained staff observe communication touch points. Our staff included members of the Center for Health Literacy, as well as the County Board of Health. The observations took place in multiple points of patient communication. So we included front desk staff responding to patients and families, medical intake or triage staff, who are the first people that patients see to start the process, and then actual health provider interactions. All of the staff members were informed beforehand of the visits, and they understood that we were there to observe oral communication with patients. Each patient was asked for consent before we observed their interaction, so we had to get that information. Our staff developed an observational tool that we adapted from AHRQ's Teachback Observational Tool and AHRQ's communication tool. The tool was reviewed by our staff and also external partners before it was approved. When we went into observations, we observed the use of oral communication skills and the specific use of the teachback method, in that we were looking for if the staff took responsibility for communication, if the staff invited the patient to teach back the information and instructions, and if they did, if that staff member then corrected incorrect information or added any additional information that appeared that the patient was missing. We rated their interactions on those elements based on a scale: never, rarely, occasionally, frequently, and always. And then those were each assigned a numerical value for evaluation. The assessment results we received from our observations showed low scores in the use of teach-back method in those clinics. Other projects focus strictly on training individuals in the teach-back method. We held 8 separate trainings for 66 public health providers from different service areas and from different geographical areas across one state. The trainings were presented online and in person, and they were approximately 3 hours in length. The training was actually designed for public health workers who communicated with patients and family members as the key element of their job. The training included lecture, group exercises, and then a large segment of individual teach-back practice where they received feedback from their peers along with trainers. At the end of the training, each participant was asked to complete an evaluation on the training. The overall evaluation results for the trainings were favorable, showing over 90% improvement in all objective areas, including participants' perceived increase in skill and knowledge and their increased confidence that they could implement the skills needed in their practice. 97% indicated improved ability to be able to describe the rationale for assessing learner feedback. 91% indicated improved ability to describe the skills needed for verbal instruction and ways to address health literacy limitations in learners. We saw 95% improved ability in participants to use their own style to create an invitation for teach back with their patients or their clients, and 95% improved ability to use the teach back in a non-shaming way. Our findings, even though healthcare workers may not be trained in teach back during their education, they can be trained trained as staff of an organization during continuing education, and in some cases, onboarding experiences. We found that training healthcare workers in the teach back method actually improves their perceived skills and knowledge, and also their confidence in using the method. We believe this could ultimately lead to better patient understanding and improved health outcomes if providers will consistently and correctly use the teach back method. We also found that follow-up is needed for determining the long-term impacts of this training, and we are in the process of working on creating a follow-up plan with our partnerships. These are my citations. And this is the information that you can use to get in contact with me. As I said, I work for the Center for Health Literacy. If you want to know more about our work, if you want to receive information from us, including our monthly blog, you can just scan that QR code and it'll take you to our site where you can register. Thank you very much for your time.
Thank you so much. It was a very interesting presentation and use of teach back. A lot of us in the health literacy field know how important teach back is, and we've used that a lot in training in the past as well. Please, everyone, put some questions into the question and answer if you have some questions for her regarding the presentation. I'll just kick off and talk a little bit about, I'm curious what the teaching method, how you chose the teaching methods that you did, and is that something that your program has used before too and found to be effective? Or was it something new you tried for this project, and how did you all develop those?
We have provided teach back training in the past throughout our teaching hospital and to other partners who contracted with us. We did an assessment of the individuals that were going to overall who were going to be trained. And then we did try to adapt our presentation and training to fit more their particular work that they're going to do. And also we utilized information from their strategic mission and vision and plans to indicate the need and also the requirement of providing teach back education or information, clear understanding information to the patients that they serve. And that made the training a little bit more personal and made it hit a little bit closer to home, where they could see where this tied in with their actual organization's mission and vision.
Yeah, that makes a lot of sense. And I agree, tailoring your education makes it much more valuable for those that are attending. One question from the audience, did you do any observations after training, and what did they show?
No, that's what we are hoping to do in the future. At the time when the grant ended, there was no longer any money to support that, but we have made additional contact with our partners to see if that might be something that they'd be interested in the future, so that we could look for funding that would allow us to do that.
And then one more question, thank you for that. Can you describe more about how policy and accrediting bodies can and are impacting use of health literacy strategies?
From my research findings, I found that most healthcare professionals don't receive any training on true the teach back method, and the training they receive in oral communication is more empathetic training to try to respond to individuals' feelings, and not as much geared towards actually making sure that the information we communicate is absorbed and patients take that information in and are able to use it. I think that what I did find was that we are trying to move towards that with endorsements from different organizations that see that it's important. Part of our project when we worked on organizational health literacy, we not only assessed the use of teach back, but we also assessed individuals' organizations' policies and procedures. And even though most organizations had something geared towards patient communication in either a policy or a procedure or a perceived action, they weren't really following those. So when they did their own internal assessment, that was something that they identified. And then we helped them with the development of improvement plans. And almost all of our organizations, I think probably around 80%, included something geared towards improving the use of either the teach back method, or improving or adding the teach back method into their training or onboarding skills. I think we're working towards it in this limited perspective from what I see.
Thank you. A couple of these questions came from some of our organizational health literacy colleagues that I've worked with for years. And so it makes sense. There's a lot of work going on out there. And I think we could have a great discussion about this at the end if we continue to have time. So thanks so much. I appreciate it.
Thank you.
All right, we'll move on to our next presenter for the next abstract. This next abstract is enhancing health literacy through the synergy of confidence, compassion, and personalized healthcare. If you'd share your screen, we'll be all set.
Can you see my screen sharing?
Yes, we see it. Thank you.
Hello, everyone. Today, my name is Suntaek Kim. I'm from Morgan State University, and I'm not actually in this discipline, health literacy. I'm in service marketing and management in the business school, but today I'm honored to present the research conducted by Hailey Hwiram Kim from Children's National Hospital in DC. And this research explores how confidence, compassion, and personalized patient care can work together to improve health literacy and health experience. So I'll be presenting the findings on behalf of Hailey Kim. And health literacy is important for effective communication in healthcare. because it allows patients to understand their treatment options and make informed decisions and engage with their service providers. Without it, patients may struggle to understand their healthcare journey, which can lead to the poor outcomes. So patient experience is reflection of health literacy and is influenced by the way healthcare providers interact with their patients. So for this study, we focus on three key factors that can drive patient experience, patient provider confidence, personalized care, and provider compassion. So these factors can improve health literacy and also can contribute to more equitable healthcare outcomes. So to better understand this study, it's important to define the key concepts here. First, patient-provider competence refers to the trust patient place in their provider's medical judgment and experience. Second, provider compassion is about showing empathy and concerns for patient well-being and creating more human interactions. Third, personalized care is an approach to healthcare where treatments and interactions are tailored to meet the specific needs, preference, and circumstance of each individual patient rather than using a one-size-fits-all method. And finally, patient experience includes patient overall experience and satisfaction. The patients have their care. So here are the objectives of this research and hypothesis. The primary goal of this study was to examine how confidence, personalized care, and compassion collectively impact patient experience and how this can in turn promote health literacy. So we formulated these three hypotheses. First, we hypothesized that patient-provider competence would have positive impact on patient experience. Second, we predicted that the provider compassion would mediate the relationship, meaning that compassion might be the mechanism that explains the relationship between the patient-provider competence and patient experience. And third hypothesis suggests that we hypothesize that personalized care would moderate the confidence and experience relationship, suggesting that in personalized care settings, the importance of competence might decrease. In other words, if personalized care is high, then the positive relationship between the confidence and experience might be weaker, that's suggesting the negative moderator. So personalized care would play a negative moderating role, making the effect of confidence on experience less significant. And this is a brief research model that shows the hypothesis that I just mentioned. And method to test the hypothesis, we conduct a cross-sectional survey of 250 patients from the United States, recruited through Amazon Mechanical Turk. And participants rated their healthcare experience using validated 7-point Likert scale, and we analyzed the data using linear regression to test the hypothesis one, the direct relationship between competence and patient experience, and we used mediation analysis to explore whether compassion mediated the competence and experience relationship, hypothesis 2, and model analysis was conducted to test hypothesis 3, the exploring the modeling role of personalized care. And the results support all of three hypotheses. The hypothesis, first, we confirmed that the patient-provider competence had a significant positive impact on patient experience with a t-value of 21.68 and a highly significant p-value of less than 0.001. And second, mediation analysis also showed that the provider compassion significantly mediated the relationship between competence and experience based on the results of indirect effect. And finally, we found that the personalized care moderated the competence experience relationship, which means that in highly personalized care settings, the importance of competence decrease, suggesting that the personalized care can establish a baseline of competence, reducing the need for high levels of competence in the service provider. So this is a result of mediation analysis that shows, as you can see, the total effect of confidence on patient experience on path C was here 0.77, standard error 0.4, 0.04, and t-value 21.68. And so more importantly, indirect effects through provider compassion, path A multiply B was 0.25 and t-value 4.52. And hypothesis 3, this shows the results of moderation analysis here. And the interaction terms, negative coefficient of minus 0.8 and significant statistics t-value show that as personalized care increased, the positive impact of patient-provider confidence of patient decreased, confirming the significant negative modeling effect. And our findings show that while confidence is important in patient-provider relationship, the impact is significantly improved, particularly when paired with compassion. So compassion, empathy, can strengthen the confidence, trust, and emotional connections that can lead to higher patient overall experience. Also, personalized care can create a baseline of trust, making patient overall experience less dependent on confidence alone. So, and together, provider confidence, compassion, personalized care can create healthcare environments where patients are more informed, more involved, and more satisfied with their care. And here is the implications for practice. So the results of this study can bring some insights into healthcare practice. First, compassion is not just an extra. It plays a big role in improving how patients experience care. It actually can make confidence more effective. So even if a service provider, the experts, doesn't build trust, focusing on compassionate care can still lead to better outcomes. This means that healthcare training can elevates compassion from something secondary to a core part of how we teach patient interactions. We also see that personalized care can help bridge the gap when the confidence is lacking. So by tailoring care to each individual, providers can still build a strong foundation of trust, even when they have limited time or high patient loads. This is especially important in busy and resource-constrained environments like healthcare environments. And another key point is that confidence is not just about the provider skills. It's about building mutual trust with patients. So providers who use clear communication and share decision-making can foster this trust, moving beyond just being experts to becoming collaborators with their patients. Lastly, as healthcare evolves, tools like AI or some kind of predictive analytics can be used to improve personalized care, not replacing the human connection. These technologies can help providers deliver more tailored, more compassionate care, ensuring that patients feel heard and understood even in tech-driven settings. So this ends the presentation, and any questions?
Thank you so much. That was very interesting analysis and interpretation. So I think we'll have some good questions about this. Please put some questions in the Q&A for our speaker would be great. One question that I was hoping that you would discuss is actually about the mechanical Turk approach to surveys and how other people might be able to use that. And I'm curious how your IRB at your institution approached this, because I think different institutions have different views on using the mechanical Turk for surveys.
Yeah, thank you for the question. Amazon MTurk, Mechanical Turk, is an online crowdsourcing platform where business and researchers can hire individuals, so-called workers, to perform small tasks, including surveys for payment. So to collect survey data, researchers can use MTurk to post their surveys as tasks, allowing respondents workers to complete them in exchange for compensation. Compensation can be chosen by the researchers, and this can provide a quick and affordable way to gather from a large and diverse pool of participants. But for IIB-related matter, so we went through my institution, IRB, Morgan State in Baltimore, IRB, and then we provide details about compensation. And because the study anyway involving human subjects, so there were some questions about particularly about compensation related matters also. And then for research perspective, there might be an issue here whether the sample can be representative because because especially in terms of health literacy study and because people with like can have access to Amazon MTurk platform can respond to the survey because that can raise an issue in terms of sample representative. So does that answer to your question?
Yeah, no, I think it's really interesting. I just think it's an interesting way to get survey data of a very big population, and I don't know that everyone knows about it. But I think one of the limitations is you don't get demographic data unless you ask it in your survey, correct? And so if you
Yes,
don't,
we collected demographic information. Yes, we collected the demographic
oh, you did.
information.
Mhm.
Yes, but we didn't use demographics to control but we collected demographics. Yes.
And in your demographics, what did the education level look like or income look like? Did you collect those variables?
I cannot quite recall because I cannot quite recall right now. So
Yeah.
yeah,
I
I'm
think
not
it's
sure.
important part of the interpretation though is to just understand who the population is that is having that this applies to, because I don't know that it'll apply to all of the population because you have to be on a computer, you have to be online, etc. But it's a really great way to reach a population of people fairly easily. I think the
Yeah.
analysis is very interesting and gave um, some I wouldn't say different than expected, but some great highlights of how you might be able to address some of communication barriers and improve experience. And when I read your abstract, I didn't get the piece about what you might suggest people could do to improve patient provider confidence, but it seems very much like those pieces are all health literacy pieces. So engaging in shared decision making, providing clear communication, but I'm curious, what does that personalized care piece look like when it's actually put into practice? As you're saying, it can be really short, it could be implemented fairly quickly, but what does that look like? Like if somebody was to try to take that idea of personalized care, because that moderates some of that effect. So that might be one way also to, enhance our experience.
Yeah, thank you for the question. And personalized care, as I mentioned earlier, that are treatments and interactions are tailored to meet specific needs and preference for each individual patient. So when it comes to service, there are two ways generally, right? Standardization and customization. So personalized care is for more advanced concept of customization. In other words, like uh, like more like a patient-centric approach, I say. So understanding patient needs and preferences and circumstances for each individual patient is the key to the concept of personalized care, like more like patient-centric care, I say.
And that might be outside of like an individual provider, but like rather the whole clinic being personalized. Is that to that person's care, that there's more than just one person, it's the whole team that knows their care and is getting them what they need?
Oh, yes. Yeah, because
And
actually new in this discipline, health literacy, but I'd like to know, and also I'd like to be involved in also in this community to learn and can potentially advance to health literacy, especially because as I mentioned earlier, I have expert in service marketing management. So marketing
Mhm.
is all about like setting service promises, delivering service promises, and enabling service promises in healthcare setting, which I learn about health
Mhm.
literacy. Even this study was conducted by a students actually who wants
Mhm.
to know about health literacy. So, but she cannot make it, so that's why I'm presenting on behalf of the students.
Mhm. Yeah, thank you very much. It was a it's an interesting study, and hopefully we can discuss a little bit more at the end if we have some time too.
Thank
We'll
you.
move on. Yeah, we'll move on to our next presentation. The next abstract is communicative health literacy and the use of healthcare services in Hungary. If you want to bring up your slides.
Hello, hello. I'm sharing my presentation. Okay, could you see that?
It hasn't quite shared. It looks like it is sharing, but
Uh,
I don't-
and now?
it's not there now.
Okay.
Could you go ahead and reshare?
Yes, I am trying to reshare it. And now? Is it working?
We see the presenter view, yes.
Okay.
We see the slides. Yeah, it's not a slideshow, it's the slides.
And now? I don't know why is it not working.
If are you working off of multiple screens right now?
No, I have got only one screen.
Okay.
Mm,
You can,
okay.
you can share it as a slideshow. You just won't be able to see your notes if you prefer that.
Okay. And what
Perfect.
about now?
That's it. Yep,
Perfect.
that's it.
Okay,
Perfect.
okay, okay. I'm so sorry about this technical problem. Yes, okay. Hello, everybody. My name is Ferenc Vince, and first of all, I want to say thank you for the opportunity to introduce our work, which is connected to analyzing how communicative health literacy affects healthcare services in Hungary. Recent studies demonstrated that patients with low health literacy have higher chance for chronic diseases or follow unfavorable health behaviors. Scientific literature also suggests that there is a strong correlation between low health literacy and more visits of emergency care or more hospital stays. But at this stage, we also need to communicate that these results in many times were strongly influenced by what kind of domain of health literacy being studied or what kind of questionnaire we are using when we are analyzing health literacy and healthcare utilization. Based on this, we also know that communication between patients and doctors plays a vital role in healthcare. And there is a special domain of health literacy, which is measure the quality of the communication between patients and doctors. And this is the communicative health literacy. More formally, we can define communicative health literacy as patients' communicative and social skills that enable them to actively engage in face-to-face encounters with healthcare professionals. And based on this definition, we can also hypothesize that communication health literacy can also play a very important role in the management of the patient's health or in the management of the chronic conditions. And we can conclude that if we have got better communicative health literacy, it maybe can lead to less use of healthcare resources. But if we check the scientific literature, we can find that this topic is not widely studied or deeply understood. And that was the reason to forming our aim, which was how communicative health literacy connected to healthcare utilization. And in the same time, we wanted to analyze the moderation role between communicative health literacy and healthcare utilization. Hungary participated in the latest European Health Interview Survey 2019, and we used this database for forming our analysis. We conducted a cross-sectional nationwide representative survey in the end of 2020 using the CATA survey mode. We collected information about the respondents' sociodemographic variables. We also measured the communicative health literacy and healthcare services. More deeply, we used the 6-item version of the HLS-19 communicative health literacy instrument to quantify the respondents' communicative health literacy. In the analysis, we handled this measure as a continuous care, where higher score indicated higher level of health literacy. In case of healthcare services measure, we used the latest European Health Interview Survey questions on how many GP visits conducted the respondents. We also measured the emergency services use, the medical specialist visits, inpatient and day patient services usage. For analytical purposes, we created binary categories as an outcome. In case of emergency services, medical specialist visits, inpatient and daycare services, we used the categories 0 and 1 or more use, where 0 indicated not used, the other categories indicated use. In the case of the GP visits, we used the thresholds 0 to 2, which indicated low usage, 3 or more use indicated higher usage. We applied a multivariate logistic regression. All analyses or all associations controlled for the socio-demographic variables of the respondents. And after that, in the second step, using interaction terms between communicative health literacy and socio-demographic variables, we conducted a moderation analysis. Just a brief insight into the study example. You can see that the male-female ratio was almost the same. Approximately 21% of the respondents belonged into the university or higher educated category. 30% of the respondents had 65 or older ages. According to the univariate descriptive analysis, we found no significant differences between males and between the studied age groups when we analyzed the mean communicative health literacy. If the respondents had primary or less education, the mean communicative health literacy was significantly lower compared to those respondents with secondary education level, and who indicated that the self-rated or the self-perceived health was good. Among those, we measured the mean communicative health literacy significantly higher compared to those whose reported their self-perceived health as bad. Based on the multivariate logistic regression analysis controlled for the respondents' socio-demographic variables, we found that communicative health literacy significantly connected to emergency and inpatient care use. We found that increased or better or higher communicative health literacy decreased the odds or decreased the chance of the emergency and inpatient care use. In the second step, We conducted a moderation analysis where communicative health literacy considered as a moderator between sociodemographic variables and healthcare utilization. Only in one case we found significant interaction term. The studied outcome in this case was the inpatient care use. We found a two-way interaction between sociodemographic variable and communicative health literacy. And as the interaction plot suggested that somebody's with increased self-perceived social status combined with above average communicative health literacy, the inpatient care use was lower. We also found a two-way interaction between education and communicative health literacy. We also found that the odds of inpatient care use was lower among those with vocational, secondary, and university educated patients combined with better or higher communicative health literacy. In conclusion, we found that communicative health literacy independently connected to less use of emergency and inpatient care services, and this results was controlled for the sociodemographic variables. And in the case of the moderation analysis, we found that communicative health literacy moderated the effect of education and self-perceived social status on the inpatient care use. We found that patients with higher socioeconomic status and with lower communicative health literacy, they used more frequently the inpatient care. On the other hand, patients with higher CES combined with higher health literacy rate, we found lower odds the usage of inpatient care. Among lower educated people, the probability of inpatient care use was higher, and the higher communicative health literacy cannot be neutralized this risk effect of the lower education according to our analysis. In conclusion, we found that poor communicative health literacy is associated with more emergency and more inpatient care utilization. We also find that communicative health literacy moderated the effect between socioeconomic determinants, such as self-perceived social status and education level and healthcare utilization. And based on our results, an important consideration for future studies should be to identify other potential influencing factors and to determine which variables have mediating, moderating, and confounding effects on the causal relationship between communicative health literacy and healthcare utilization, because there is a very problematic and very the link between communicative health literacy and healthcare utilization is very complicated, and that's why we need to figure out which factors has a direct effect on healthcare utilization and which factors are mediating or moderating the healthcare utilization in this context. Thank you for your valuable time. Thank you very much.
Thank you so much. That was a very interesting presentation and very interesting analysis that, you know, goes along with some of what we know in the literature, but again, is showing us new things regarding how important health literacy is as that moderating factor that I don't know that people take enough into account when we're thinking about improving health in those with some of those sociodemographic characteristics like low SES and low education attainment. So one question I have for you, and please others add some questions to the chat or to the Q&A so we can have a little bit more discussion too. What is your idea of why that communicative health literacy wasn't associated with the GP visits or specialists? do you think that was do you think that's actually true in the world, or do you think that potentially there's something with analysis that didn't lead that to happen? You know, such as you could use like those visits as a continuous rather than a discrete variable. You'd have to change the analysis a little bit, but you know, I've done ED utilization research and we often use it as a continuous variable rather than, you know, putting it into the categories. So I'm curious if you think that's just inherent and that is how that what is true in the world, or potentially we just didn't find it in this study.
Thank you for your question. We found that communicative health literacy only connected to emergency and inpatient care. And it is a good question, why not correlated communicative health literacy with GP visits or day patient care or medical specialist services. It is a little bit country specific at this case. Because, for example, the GP works in Hungary as a gatekeeper. The first point where the patients are meet for the healthcare system is the GP. And people with low health literacy also meeting GPs, and people with high health literacy also meet the GPs, but because different reasons. For example, I can imagine that a patient with low education visiting the GP because they has problems or managing the chronic conditions. But in case of patients with a higher health literacy rate, they are visiting the GPs because he or she considering why important to care about health, or wanted to attend in primary prevention programs or in vaccination campaigns. And that's why we can see, for example, differences between low or high communicative health literacy and the number of the GP visits. The day patient care also a little bit specific in Hungary, because the day patient care is connected to mostly specific conditions. Like eye surgery or urinary tract surgery, and the patients has a very low control over in the participation, because they are needed surgery, and it is not depends on the communicative health literacy. They need it and they will attend on the care.
Yeah, great. There's a question in here for me, and Esther, I will answer that at the end if we have some time. Okay. Otherwise, I'll send you my email. Are there any other questions for our speaker for this abstract? All right. Let's move on to our next abstract. Thank you so much. The next abstract, yeah, thank you. The next abstract is pharmacotherapy, literacy, and insulin administration knowledge of diabetes mellitus type 2 patients. Thank you so much for being here to present.
Hello to everyone. Can you see my slides?
Yes, we see them.
Okay. Hello to everyone. My name is Dušanka Krajinović. I come from Department of Social Pharmacy and Pharmaceutical Legislation, Faculty of Pharmacy, University of Belgrade in Serbia. And today I will present some of the results from a study that we have done here at community pharmacy settings, assessing pharmacotherapy literacy in diabetes mellitus type 2 patients, and also assessing insulin administration knowledge of diabetes mellitus type 2 patients. Let me just say that this presentation is actually a part of the results from a master thesis of one of my colleagues. I will be just presenting it. So I would like to acknowledge the efforts of Ivana Stević, Eugenia Munčan, Marija Levis, Stana Ubović, and Jelena Branković. They are all co-authors of this presentation. Well, pharmacotherapy literacy, as it is in the title, it is a kind of a health literacy. It reflects the specific literacy competencies which are required when an individual is dealing with information that is medication related. So medication information are quite specific, and there are a lot of them. They came on different sources. They are widely available. So pharmacotherapy or medication literacy is a specific field that can be assessed and can be discussed from a perspective of health literacy. Health literacy related to medications is crucial in enabling individuals to manage medication properly. And it is especially important for those individuals who take their medication regularly, so who take their medication daily, every day. So for chronic patients like diabetics and other non-communicable diseases. And medication literacy assessment is essential for those individuals to obtain, comprehend, or understand, to communicate, also to process, but also calculate. So in medication literacy, we have this very important aspect, calculating something. So to utilize medicated related information that are necessary for the individual to make informed decisions concerning self-management of medication. And the other thing with medication related information and chronic disease patients is that they usually tend to use more than one medication. So they not just that they have a different sort of information that they need to understand and to use, but they also have a lot of different information for different medications. So this is a perspective that's important to consider when we are talking about pharmacotherapy literacy. The aim of this study was to determine levels of pharmacotherapy literacy at diabetic patients and to see if there is any association with insulin self-administration knowledge. And as I said, we conducted a research, a cross-sectional survey with a population of patients that were diagnosed with diabetes mellitus type 2 at least 6 months before the survey, and who received a standardized service at community pharmacies in Serbia. And that service is for diabetic patients and is provided by diabetic advisory pharmacies. So this is a survey that was introduced 2 years ago in Serbia by the Pharmaceutical Chamber of Serbia, and only those pharmacies that are educated to become diabetes advisory pharmacies could provide service. And regularly, when they provide service, they survey patients, so diabetic patients, with 20 questions concerning knowledge of insulin administration, if the patient is using, of course, insulin. Our sample was convenient. You see the time of our sampling was from November last year till August this year. And we used specific survey instrument, pharmacotherapy literacy questionnaire for diabetes mellitus, which is a survey that we developed in previous studies. And also this, as I said, standardized instrument with 12 questions to assess knowledge of insulin self-administration. Analysis was descriptive statistics, and we use Pearson He-square test to use the determined level of pharmacotherapy literacy and association with the knowledge of insulin self-administration. The instrument that I said that we used, that we developed in previous study, is objective instrument. It is a self-reported instrument concerning medication, pharmacotherapy literacy or medication literacy in Serbia. And it was specific because it was developed for this kind of population, for diabetic population. The instrument has a score from 0 to 15. And based on these scores, respondents were classified into 3 levels of pharmacotherapy literacy: low level, lower than 8 or 8, medium 9 to 11, and higher level would be 12 and higher. In these instruments, there are 15 questions, and they are divided into 4 groups based on definitions. And these questions are, I think I might not use the right presentation, but anyhow, I will go on. So we have 4 groups of questions: access to information, 2 questions; understanding, 3 questions; interpretation, 4 questions; and use of information, 6 questions. And when I say use of information and interpretation, those are questions that also include calculation, which is, as I said, important for this kind of literacy. In this instrument, 11 questions were medication specific, meaning that they are a patient with we will be assessing the medication name, then the dosing information, treatment indication, precautions, time and prediction of therapeutic effect, and so on. So it will be a hypothetical prescription labels as a part of the instrument. So patient, as I said, it is an objective instrument. Patient would have a task to perform and to see how actually they would dose this medication, or how they understand the information, how they will follow the instruction. 2 questions were related to interpretation of the composition, natural nutritional values, and declarations. So it was not about medication, but dietary supplement. And also 2 questions were related to disease, so general health literacy, and were not medication specific. The results of our study, here you can see the characteristics of a sample. 227 participants with diabetes mellitus, at least 6 months. Majority of our sample was female, and participants were a bit older. Average year was 67, with high school education. More than 60% were with high school, and dominantly from urban areas, because we perform survey in one pharmacy chain in a big city that has several surrounding areas, rural and villages. So we have some patients from rural areas, but predominantly are patients with urban areas in our survey. And patient using insulin, so they were all diabetic patients, but some of them used insulin, 48%, and 52 were with other therapy for diabetes, but not insulin therapy. The average score of pharmacotherapy literacy of our sample was low literacy, so 8.30, which is actually low. So our patients were pharmacotherapy unliterate, low literate, and also patient using insulin scored 7.98, which is also in the level of low literacy. There were no difference in pharmacotherapy literacy levels among patients with diabetes who were and who were not using the insulin. So there are no differences, but as I said, the whole sample was with low health literacy. And here you can see the distribution of levels of pharmacotherapy literacy level. So we see that predominantly we have patients who are low literate in both subgroups, in those not using insulin, those using insulin, and in the whole sample. And only 11% in all groups were with a higher level of pharmacotherapy literacy, and we need patients to be at least at medium level so that we can be sure that they use their medication properly, especially those patients chronic, as they perform and they apply their medication at home. So we are not we cannot help them with applying medication. And for those therapy, insulin therapy, you need to have a different skill, but also knowledge how to apply that at home. So for the medication literacy and chronic patients, we tend to have patients at least at medium literate and preferably with high literacy. Patient using insulin, when we looked only this subpopulation, and we looked at the pharmacotherapy level, we observed some significant differences for the following factors. First, marital status. People that were living in people that were married, for example, married couples, they tend to be higher literate. Then also those that were with a higher employed status, so that were steady employed, and also those that are physically active. So active physical exercises, we found more people with a higher pharmacotherapy literacy group among those that are physically active. And of course, those that use proper health information source. When I say proper health information source, I mean healthcare professionals as proper health information source, preferably pharmacists and physicians. In our research, patients tend to use physicians as a first health information source. And there we can see the pharmacotherapy levels related to knowledge of insulin self-administration. As I said, insulin is a specific because you need to develop skills for self-administration, but also to know where to administer, how to administer. There are some schemes that the patient should be aware of and follow strictly. And also when we are talking about pen insulin, administration techniques vary, and actually those techniques are very related to things like pen preparation, accuracy of dosage, needle application, complete dose application, then withdrawal of a needle, which is important when to withdraw it, and also is it possible to reuse the same needle when it is okay, cleaning the needle after administration, the frequency of skipping insulin administration also important. And you see that we in all these knowledge on insulin self-administration, we observed significant differences of pharmacotherapy literacy levels. So those that are with low pharmacotherapy literacy were predominantly in a group that were not knowledgeable concerning all these. And also we observed the role of pharmacists. As we were conducting the research in a pharmacy, we wanted to see if our patients think that pharmacists has any role in improving knowledge related to drugs and their use. And we see the difference between the patients who use insulin and the patients who don't use insulin, especially to some answers. Some answers were important for us as how they perceive pharmacists' role, what pharmacists can explain concerning drug, concerning writing the information, concerning clear information or write clear information on packages, and also giving all necessary information. And people tend to rely on pharmacists, those that use insulin, which is explainable because they depend on the information pharmacists present to them. There are several limitations to this study. This study, first of all, is like a pilot study. It's a small scale study. It's a cross-sectional study. Our sample was convenient. We performed actually research in one center in an urban area, but as I showed, we have some participants from villages, and also it was self-reported at a community setting of pharmacy, which is not an ideal place to perform a survey because it could be crowded. People are not usually alone in the pharmacy, so there are many obstacles to do research there. So the conclusions would be that in our study, every second patient using insulin was low pharmacotherapy literate, and pharmacotherapy literacy levels are related to knowledge of insulin self-administration. So we see that this research could be further developed and carry on. so that we can learn something, how to target interventions to improve knowledge of self-administration to patients with diabetes that use insulin, and they are frequent and regular customer in community pharmacies these days. Thank you for your attention.
Thank you so much. Appreciate you being here to present the research. A very interesting look at the patients with diabetes and their knowledge, and I think this is a great use of the measure to understand what's happening with these patients in real life. What recommendations do you have for developing the targeted information, knowing that at least half of them or around half of them have really low literacy? How might we be able to address this? Any thoughts?
Thank you for the question. I think that the first we need to work with pharmacists to enhance them with the skills how to recognize, how to spot the low literate patient. And after that, I think that pharmacists would take a better care of those patients that need to be counseled in more detail or in a simpler way. Teach back techniques, as we heard in the first presentation, was something that we tend to use with a pharmacy to as a training, but also I think from this kind of research we can describe the low pharmacotherapy literate patient, so that pharmacy could better spot them, quicker spot them. And usually it is when we are talking about chronic patients, it's usually patients that don't have many questions, that they reply with yes, I understand, yes, I will read it at home, my children will help me, I don't have spectacles. So with those answers, they're usually a patient that should be taking a better care. And of course, patients that are with lower education, that are older. In our research also, people that are without children and living alone, they are more likely to be low literate concerning medication. Because in some previous research with the parents of preschool children, we identified predictors for a lower pharmacotherapy literacy, and the number of children actually is very important predictor, because when you have children, you need to develop skills concerning medication usage, and also you need to develop skills to deal with medication information, because it's very important for parent when they are giving medication to the children. And so more children tend to build these skills. So sometimes even this factor could be useful for pharmacists to take better care of those that live alone or that live without children, to take more time and in more details to explain the information.
Mm-hmm. Yeah, absolutely. The liquid medications in children is a big challenge, and there's frequently underdose and overdose, just like drawing up medications like insulin. Absolutely. Thank you so much. Let's move on to our last presentation so we can get to it. Appreciate you presenting here. And then our last presentation by Zenaida is the Assessing Health Literacy Needs of People with Type 2 Diabetes Mellitus, a cross-sectional study using the Health Literacy Questionnaire. Thank you so much. We can see your slides.
Hello to everybody. My name is Zenaida Alexa. I am endocrinologist at the Republican Clinical Hospital from Republic of Moldova. I am really honored to participate at this event, and in the next 10 minutes, I will try to present some results of the study conducted jointly with the School of Public Health. In this cross-sectional study, we assessed the health literacy needs of people with type 2 diabetes using the Health Literacy Questionnaire. I would like to mention that I have no conflict of interest to declare, and some data about Republic of Moldova. I should mention that it is a small country and has a population of approximately 2.5 million. And diabetes, it is a common problem for our country. And concerning the situation of diabetes in our country, the total number of people with diabetes has tripled in the last 20 years, and the number of new cases detected annually exceed 10,000 persons. The problem of diabetes is not only the increased number of people, but especially the development of chronic complications that occur when therapeutic goals such as A1C level, blood pressure, weight, and LDL cholesterol are not achieved. Achieving and in particular maintaining therapeutic targets require a range of basic but also complex knowledge of the person with diabetes. And in this context, we note that health literacy is a determinant of individual and public health. Insufficient health literacy is one of the most important barriers in the care of people with diabetes. And in people with diabetes, low health literacy is associated with failure to achieve therapeutic goals for clinical and paraclinical parameters. However, despite having evidence-based recommendations and new classes of drugs, a very large number of patients don't achieve therapeutic target value. This became a very big problem. What can we do in this case? Our research focused on the people with type 2 diabetes. We set out to examine the population with diabetes who go to medical institution for medical services, and we aim to evaluate the following. How easy is it for people to find out what our services does? Are our services tailored to people's needs or abilities? How well do our services providers engage with clients? As a clinician, my dream is to increase the rate of people with diabetes who are engaged in self-management of their disease. And to achieve this, we aim to assess the strengths and challenges people with diabetes face in terms of health literacy. The aim of the study was to use a multidimensional measurement tool to describe the health literacy of adults with type 2 diabetes mellitus for understanding where the greatest difficulties and need of people with diabetes in assessing, in obtaining, understanding, appraising, remembering, and using information about health. In our cross-sectional study, we included 490 people who completed the health literacy questionnaire, and we collected data on socio-demographic and clinical indicators. The mean age of the participant was near the 60 years, and 50% of participants were under 60 years old. I will present brief data on demographic and social indicators of our study. Women being slightly more prominent than men, most participants were from rural area, 1/3 had higher education, almost half of people were retired, and most participants were married. As we observe, most participants had been living with diabetes for 1 to more than 16 years. An important aspect was to assess the rate of people who have reached the target level of diabetes control, defined as an A1C level value less than 7%. We found that only 25% of respondents had achieved these targets of A1C. This data confirm the necessity and importance of this study. The health literacy questionnaire comprised 2 compartments. The first compartment gathers 5 domains that describe the social dimension of the issues, while the second compartment consists of 4 domains that explore patients' lived experience in their interaction with medical staff. In the first compartment of the questionnaire, the highest score was achieved in the domain of feeling understood and supported by healthcare providers. This indicates that most people with type 2 diabetes have a stable relationship with at least one doctor who knows their health issues thoroughly and whom they trust implicitly. The greatest difficulty in the first part of the questionnaire were reported in the domain of having sufficient information to manage health. This suggests that individuals recognize gaps in their knowledge that hinder their ability to fully manage their health issue. The second section of the health literacy questionnaire specifically assessed people's skills in orientation and performing specific activity related to health literacy. Here we observed that virtually all scales yielded similar score. The highest score was obtained for ability to actively engage with healthcare providers, indicated that individuals with type 2 diabetes are to some extent proactive and are able to seek advice from doctors when they need it. Conversely, the lowest score in this section was for ability to find good health information, suggesting that these individuals may struggle to access health information independently, relying instead on others to provide them with necessary information. We tried to identify whether there are differences in scores when analyzing different demographic and social indicators. Feeling understood and supported by healthcare professionals and ability to actively collaborate with healthcare providers scores were found to be statistically significantly lower for people living in cities. People with more education showed significantly higher score in most domains, except for the scale actively managing my health and social support for health. Social support for health, appraisal of health information, navigating the healthcare system, ability to find good health information was registered significantly higher score for people living with their families. In conclusion, our study revealed that individuals with type 2 diabetes scored highest in domain reflecting feelings of being understood and supported by healthcare providers, as well as the ability to actively collaborate with them. This characteristic represents the interactive component of health literacy. Conversely, the lowest score were observed in domain related to the functional component of health literacy, such as having sufficient information to manage health, evaluating this information, and the ability to find high-quality health information. The study also revealed differences in health literacy questionnaire scales based on patient demographic and clinical status. What to do after this study to address this deficiency in the functional component of health literacy? Collaborative efforts with healthcare professionals are essential. The identification of weakness in health literacy underscores the importance of additional training for medical staff, including educators, as well as the development of standardized materials for individuals with diabetes. In closing, I extend my sincere gratitude to my colleagues from School of Public Health and the Republican Clinical Hospital, and thank you for your attention.
Thank you so much for your presentation. Those are beautiful pictures. I want to come visit. So I think this is a really nice look at using the health literacy questionnaire that ties in with our keynote presenter yesterday. And he talked a little bit about kind of those archetypes that can be developed using cluster analysis. Do you feel like that is what you found when you found some of those demographic differences, such as living with cities, in cities, et cetera? Is that those are potentially some of those clusters of archetypes, you know, and is that what you think you found, or is there other things that you got from the data to suggest those?
Okay, we did the cluster analysis, but in this presentation, it is a lot less of time for presenting.
Right,
but
right.
it is a similar data as presented yesterday by Richard Osborne. Some demographical data we want to study more complexly, because it is not, I show that only in the city, the relation between healthcare providers and patient, it is not so closed as in rural area. Because in rural area, all people know each other, but in the city, it is a little bit different relation between doctors and the patient. And another social determinants as level of education, it is also showed that it is a high level of education for health literacy, for high level education.
And then there's another question from another attendee. Other presenters have talked about difficulty with appraisal. And it's interesting that it shows up in this study as well, which I think we kind of just discussed. That, you know, the trying to appraise the results. Do you feel like it's the results that you obtained, do you feel like they're helpful for future interventions? Do you feel like you were able to appraise what you wanted to about the population, or were there difficulties, I guess is kind of the question.
It is difficult to say. I try to include the population from different regions of the country for more convenient data, but it is difficult to say what is a characteristic for this.
Well, thank you so much. And I appreciate you all being here to present today, and all of the attendees for being here. You know, I just want to take us back kind of through what we went through today, and I wish we had a few more minutes for discussion, but our first presenter talked about how we can implement some of the teaching into practice and how we might do that, specifically talking about teach back method. We were able to hear more about some of the in-depth analysis of communication techniques, and also sociodemographic variables, and how health literacy actually is a higher moderator of healthcare use than that, which can bring us back to using that data to advocate for policy change within national or organizational places. And then some very interesting data regarding health literacy and patients with diabetes. And I think we looked at a couple different methods of that, both using measured skills and then personal rating of skills with the health literacy questionnaire, to hear more about how diabetes patients are functioning with their disease. So thank you all, and I wish we had more time for discussion, but I appreciate everyone's attention.
Thank you, everybody. It's really great to see the work that is sprouting up in all these different places. It's really just nice to see, and thank you for sharing and coming in all these different time zones to participate with us today. There's a half-hour break, and then the conference will continue in a half an hour. So thank you all. Be well.